My name is Rajeev Ramchand. I'm a senior behavioral scientist at the RAND Corporation. I'm an epidemiologist by training, and I have been studying suicide prevention for nearly a decade here at RAND. The suicide problem is really a multifaceted problem. We've experienced a nearly 24% increase in the rate of suicide in the United States generally. And we know, and that increase has been seen among all age groups, among both genders, and among all race categories. So it's a universal, it's a national problem, it's a public health threat. We've also seen it, and a lot of attention has been put on the crisis really within the veteran community as well as among military servicemen and women. So in the veteran community, what we often hear is the startling statistic that 20 veterans die per day from suicide. And we know that some veterans are at higher risk. For example, in 2015, we learned that veterans who were discharged from the military with other than honorable status were at twice the risk of dying by suicide within the next 5 years after they were discharged relative to those who were discharged with an honorable status. The VA has identified in a recent report that the difference between women's suicide risk, women veteran suicide risk, is significantly greater than women who are non-veterans. We see the rate for women, the youngest cohort of women veterans is 35 per 100,000, and that's 7 times the risk that exists for women non-veterans in the United States. RAND has been engaged in a number of research efforts focused on suicide prevention, but most recently we've been doing work with the VA directly. We did a somewhat unique study where we went to the Veterans Crisis Line and we interviewed responders who take calls at the lines to learn about what they heard people were telling them. And we were particularly interested in women veterans who were calling in distress. What were the responders' experiences interacting with these women? What were the things that women were saying to them? And how were they receptive to referrals, particularly referrals to the VA, when the responders offered those referrals? So one thing that emerged was that on many of the calls, the women were talking about their experiences having undergone a military sexual trauma, and that this really caused them distress and increased their risk of suicide. But we also heard that women veterans who called were sometimes receptive to VA care, but oftentimes if they weren't receptive to care, some of the issues were that the culture of the VA, they perceived the VA to be a male-oriented culture that wasn't receptive to their needs as women veterans. The flip side of this is then when we asked them about community-based care, we often heard that they perceived women veterans thought that the care that was available in communities wasn't receptive to their needs as veterans. And what's worrisome is that could leave them without care overall. In terms of what policymakers could do to be focused on the issue about suicide risk among veterans, I think one of the first things is programs to identify high-risk groups. And it's really exciting to see that the VA has already developed some tools that can identify high-risk patients and conduct outreach to them to make sure that they're doing well, and that could be really effective at preventing suicide risk. I think that other ways we could prevent veteran suicide is ensuring that communities are really equipped to prevent suicide through evidence-based care and through accepting people of all levels and veterans as well. We can't assume that all veterans will access the VA because not all veterans are eligible for the VA, and because a lot of veterans have other sources of care or they prefer not to go to the VA. And it's their choice to go or not to go to the VA. So we really need to make sure that communities are well equipped to prevent veteran suicide. And in doing so, they can also curb the tide on the public threat that suicide poses to non-veterans as well.